So in the last class, in the conceptual anesthesia, we were discussing about how to set a ventilator and see the graphics for volume controlled ventilation. Today, we'll be seeing is that how do we do the same in pressure controlled ventilation? What exactly is pressure controlled ventilation? What are the graphics changes that can happen in pressure controlled ventilation? And is it actually better than the volume control? So what happens? It's called by different names. Pressure control ventilation can be assist pressure control ventilation, or CMV pressure control. The idea is that full control mode of ventilation is there, and it controls all the phase of breath delivered based on the set parameters, whereas exhalation is still passive. So what does the clinician set? The clinician sets a minimum of how often breaths will be delivered, that is the respiratory rate, and sets a positive pressure applied to the lungs that causes lung to inflate with the volume at a very basic level. That is what the clinician sets. The pressure delivered is constant and does not change from breath to breath unless the clinician changes it. So you have set the pressures, and we'll be seeing what all do we set. So pressure is the control parameter. In the previous talks, we talked about the control parameters and the other parameters which we need to monitor. So in pressure control ventilation, the pressure is the controlled parameter, and time is the signal that ends inspiration with the delivered tidal volume determined by these parameters as well as how the patient is behaving. Highest flow is provided at the beginning of inspiration, charging the upper areas early in the inspiratory cycles and allowing more time for pressures to equilibrate. So that is being seen as one of the benefits of pressure controlled ventilation, that the highest flow is provided at the beginning of inspiration. Initially, the and pressures are equilibrating and they're going up to the almost the alveoli, which in which the inflation is not being happening. So flow decelerates exponentially. So when you see a flow waveform in a volume control, it's a square waveform. In a pressure control, it's a decelerating waveform. It goes like this. In volume control, it's rectangular. As a function of rising pressure, and the preset inspiratory pressure is maintained for the duration of operator set inspiratory time. So you set a time, you set a pressure, and that pressure initially is being achieved by a very high flow, and then the flow is coming down, whereas the pressure is maintained. So when the pressure is maintained, the equilibration of the alveolar ventilation happens. So what all do we set? So we set the pressure limit, we set the I ratio, the rate, or the inspiratory time, two out of these three. I had explained in the previous class also. If we set two out of these three, the third is calculated. So amongst the I ratio, the rate, and the inspiratory time, we set two, depending on different modes. Then the PEEP and the FiO2. So we set this respiratory rate, pressure control, inspiratory time, and what do we do not set? What do we observe? It's very important. So in this graphic that I was taken, we set the inspiratory time and the respiratory rate, and here the I ratio is calculated, and we'll monitor that. The tidal volume is monitored because the tidal volume changes depending on the patient's respiratory mechanics. And then the inspiratory flow, we'll observe it because patient's mechanics will also monitor, change the inspiratory flow that he is drawing, and the peak inspiratory pressure. So if all the mechanics are fine, peak inspiratory pressure is usually the sum of P plus pressure control that you have set is equal to the peak inspiratory pressure. So remember what you set here, and we'll be discussing what we set routinely. So how do we set the respiratory rate, pressure control, inspiratory time, PEEP, and FiO2? So PEEP, as in volume control, we discussed, we will set around 5 to 6 in a normal patient. FiO2, we always start from 100. We do a blood gas analysis after 30 minutes or so, and then we decrease, gradually come down the FiO2 depending on what is the PO2. Then amongst the inspiratory time, respiratory rate, and I ratio, we set 2. So I had given you example in the last class and I'll repeat it again. So if you want to set a respiratory rate of 20 per minute, that means we have in 60 seconds 20 breaths per minute. We have 3 seconds for breath cycling time, which will include the inspiratory time as well as expiratory time. Now if we set a I ratio 1:1, then half of this will be inspiration and half of this will be expiration. So 1.5 seconds for inspiration, 1.5 seconds for expiration. If we set it 1:2, then inspiration is 1 second, expiration is 2 seconds. Suppose you want in a COPD patient a higher expiratory time. So you set 1 is to 3 in sometimes. So you divide 3 seconds by 4. One part of it, that is 0.75 seconds, will be inspiration, and three parts of it, that is 2.25 seconds, will be expiration. So if you set the respiratory rate and I ratio, that is how you set the inspiratory time. Suppose you set the respiratory rate as 20 and you set the inspiratory time as 0.5 seconds. So what is the expiratory time? So respiratory is 20, that means 3 seconds for one sub-breath cycle, and you set a inspiratory time of 0.5 seconds. So rest of the 2.5 seconds will be the expiratory time. So in out of these three, if you set 2, then you can actually calculate the third one. Suppose the patient is on volume control ventilation and you want to shift him on pressure control ventilation, usually start with what is the plateau pressure. So what is the plateau pressure? Pressure, that is the pressure that is required to distend the alveoli. So we set that as a pressure control. And remember, your tidal volume is dependent on pressure control as well as the respiratory mechanics of the patient. So when you set a pressure control and you start ventilating a patient, always put alarms for tidal volume as well as monitor the tidal volumes. Suppose you see that the tidal volume is less, that is less than 6 to 8 ml per kg in a normal patient, then you have to increase the pressure control or see why the respiratory mechanics of the patient is not well. It can be a compliance issue, it can be a resistance issue. So hence you have to monitor the tidal volume, inspiratory flow, peak inspiratory pressures, and the IE ratio. So this is the basic graphics of a pressure controlled ventilation. So as you can see in pressure controlled ventilation, what is the square waveform? The pressure square waveform. So that is how you recognize that that is the pressure controlled ventilation. How is the flow? Flow is a decelerating pattern. The first waveform, this is a time scaler. The flow has a decelerating waveform and it touches the baseline and then shifts from inspiration to expiration. As I had told you, the flow is the only thing which goes in negative also routinely in controlled breaths. The volume. So volume is dependent on the compliance and resistance. Compliance of the lungs and resistance of the airways plus the pressure control that you have set determines the volume that the patient will have. And remember, volume, why is it important? Because volume into respiratory is minute ventilation. So if the patient is not having adequate minute ventilation, then his CO2 will build up. So there is a pressure targeted ventilation. It is time triggered because it is all controlled breaths. Pressure limited, we set the pressure control level, and time cycled. So after a certain time that you have set, when the inspiration is over, it goes into expiration. So that is how a basic waveform, if you can set on the monitor, when you intubate a patient, paralyze him and sedate him initially and set him on pressure control ventilation, he has no any of his own breaths, then that is how the graphics will look like. So it has been postulated in some studies that high initial peak flow and decelerating inspiratory flow pattern used in pressure control ventilation. So this is the high decelerating flow and the decelerating pattern. So high peak flows and then this deceleration used in pressure control ventilation can result in additional lung recruitments and improved ventilation of alveoli with prolonged time constant. So some of the alveoli initially which are normal, they open up early and they get ventilated, but some which are diseased, which have ARDS, in those additional lung units, when you have an initial peak flow and decelerating inspiratory flow pattern, over time they get improved ventilation. So that is the logic behind it. These decelerating flow waveform results in more laminar airflow at the end of inspiration with a more even distribution of ventilation to the lungs with markedly different resistance values from one region to lung to another. So our lungs is having a millions of alveoli, and when some are diseased, some are not. Initially what happens, the normal alveoli are ventilated, and then over the time slowly it goes to the diseased alveoli also, and this has been postulated. But remember, as I talked in last class, no mode has been shown superior. This is all a theoretical thing. Ability of the mode to maintain constant airway pressure by altering the inspiratory flow rates to meet the demand of the patient. That is another benefit. So you maintain a constant airway pressure, and then the patient, if he has increased demand, will has increased inspiratory flow. While tidal volume does vary in this mode, maintaining a constant airway pressure does permit improved alveolar distension universally, instead of within regions that are more readily available. So again, diseased alveolar are ventilated slightly in a better way. And this improves dead space ventilation, improved comfort, improved VQ mismatch. Volume delivered may vary to the patient's intrinsic respiratory ability. So, how is the patient's thoracic compliance, lung compliance, air resistance, and what you have set as a setting will determine the volume that is being given to the patient. Volume can change breath to breath depending on the compliance and resistance. So, volume is dependent upon the resistance and the compliance of the lungs and actually can vary from time to time. So, if the compliance increases, the same pressure control will give you a larger volume. If the resistance increases, this will decrease the volume. So low compliance or increased resistance, the volume will decrease. So clinician, another benefit I have shown in this slide, clinician sets inspiratory time, but the patient can alter the amount of flow. So you set a inspiratory time and you set a pressure, but the amount of flow that the patient can get from the ventilator can vary slightly. And patients with air hunger like COPD exacerbation or Kussmaul's respiration, these patients have abnormal neurorespiratory drive patterns. So demands are slightly high and fixed inspiratory flows could be uncomfortable for them. But in pressure control, when they can have an increased flow, they can adjust better to this and there will be less causes of air synchrony, ventilator alarms and double triggering of breaths. So in those patients with high demands, high flow demands, you can actually try this mode of pressure control. Sometimes it is better for the patient, better for synchronizing the breaths, especially in patients with air hunger. This I have talked about how we set the I ratio and the respiratory rate and the respiratory time. 2 out of 3 we set and then the third is calculated. So this is a normal waveform in the ventilator. I had shown you the graphics earlier. Here the flow is second instead of first. So this is the pressure which goes to a constant level, stays for a duration of time, and this is the time when the expiration starts. Okay. And this is the maximum volume that is delivered. So as you can see, the flow waveform also touches the baseline inspiration in the expiration also. Had it not been touching, it had been like this, it will be auto peep or dynamic hyperinflation. Can anybody suggest what is happening here? Anybody, you can write in the chat box. Anyone? I've put an arrow where the abnormality is. Can anybody take a guess? So there is insufficient inspiratory time. So expiration starts, the inspiration time is too short. Even the inspiratory waveform is not touching the baseline. Yeah, no inspiratory pause or less inspiratory time. Great, Dr. Manimaran, sorry. So here the inspiratory time is short. It does not touch the baseline. You have to prolong the inspiratory time. And you have lots of time at your hands. So this is the flow waveform, and seeing this, you can identify, you can change the respiratory rate and the inspiratory and the expiratory time. In this one, again, the arrow is there. This I even talked about Abhi 2 minutes back. Anyone? Any guess? So ideally, the expiratory waveform should be touching the baseline. If it is not touching the baseline and the next breath is initiated, there is insufficient expiratory time. The exhalation is interrupted by the next inhalation, and this is demonstrated by the arrow above. And this is what is responsible for autopeep or dynamic hyperinflation and has got its own hemodynamic side effects. So whenever you set a ventilator, look at the graphics very carefully. In each mode, you have to see what is the normal waveform. What I have set, is it mimicking the normal waveform? Are the inspiratory thing coming to the baseline? Have I set adequate inspiratory time? Is the expiratory flow adequate? Expiration is coming to the baseline. Then in all the ventilators, you have a compliance in the resistance that is calculated. You can correlate with them. You have loops, you can correlate with them. So it is very essential. So identify this mode of ventilation. This most of you will have to attempt. Then we'll move further. Let us see, after 2 classes of volume and pressure control, can you identify this mode? We talked about this in the last class. Anyone? You'll have to guess to make me move forward. You can even unmute yourself for a minute. I'm okay with that.
Pressure control mode.
Pressure control mode, somebody was speaking. Why do you call it pressure controlled?
No, sir. Sir, it's flow is in.
So how is the flow scalar? These are all scalars. Are you all with me? You can write yes at least in the chat box. If you're all with me. So this is these are scalars. Is this okay? You can all text yes if you can identify that this is scalars. So if I explain you this, you will get the hang of graphics. Can you identify the flow, the pressure and the volume on the y-axis and the time on the x-axis? Write a yes for this. Just for this much. So we identify the mode seeing what is the square wave pattern. So flow and volume are taken as surrogates in patterns in which flow is a square waveform, that is a volume controlled. And previously, as I had shown you, here the pressure waveform was square. Here the pressure waveform was square, that is the pressure controlled. So can you see the difference between the two? The pressure waveform is not square here. Can you realize the difference? The pressure waveform is not square here, the flow waveform is square. So when the flow waveform is square, this is a volume controlled ventilation. When the pressure waveform is square, it's a pressure controlled ventilation. So as we have talked before, when the volume controlled ventilation, the pressure waveform goes to a peak pressure and sometimes goes to a plateau pressure and then comes to the baseline. Here you cannot identify that. Then second question, is it a totally controlled mode or a assist control mode? So now we know this is a volume control mode.